Bismillahirrahmanirrahim. Rabbi zidni ilma. It's fine to celebrate success, but it's more important to heed the lessons of failure. Assalamu alaikum. My name is Dr. Sadia Rafi, and today my topic of presentation is syphilis. Learning outline includes introduction, epidemiological triad, chain of transmission, clinical features, levels of preventions, and recent advances. Learning outcome. At the end of my presentation, my colleagues would have knowledge about description of syphilis, its epidemiological triads, level of prevention, and recent advances. Introduction. Syphilis is a sexually transmitted infection that can cause serious health problems if it is not treated. Syphilis is divided into stages: primary, secondary, latent, and tertiary. There are different signs and symptoms associated with each stage. Syphilis increases the risk of both transmitting and getting infected with HIV. Do HIV testing in all patients with syphilis. Problem statement. During 2018, there were 1,15,045 reported new diagnoses of syphilis, including all stages, compared to 38,739 estimated new diagnoses of HIV infection in 2017. Of syphilis cases, 35,063 were primary and secondary syphilis, the earliest and most transmissible stages of syphilis. In 2018, the majority of primary and secondary syphilis cases occurred among gays, bisexual, and other men who have sex with men. Congenital syphilis, which is syphilis passed from pregnant women to their babies, continues to be a concern in the United States. During 2018, 1,306 cases of congenital syphilis were reported compared to an estimated 73 cases of perinatal HIV infection during 2017. Epidemiological triad includes agent, host, and environment. Agent. Treponema pallidum is a spirochete bacterium with various subspecies that causes the disease syphilis, Bijal, and yaws. It is transmitted only amongst humans. It is a helically coiled microorganism, usually 6 to 15 micrometer long and 0.1 to 0.2 micrometer wide. It has 6 to 12 coils, not seen by light microscopy, best seen by dark field microscopy. It has bendings and rotating motility. No culture may survive in the blood. As you can see, its diagram, it's a gram-negative bacterium. It's an obligate parasite, spirochete. Endoflagella is a protein filament which is in a spiral shape. Then it enters to external genitalia and mouth, skin, and mucosa of the membrane and leads to syphilis, which is a STD. Host. Only known natural host is the human. Transmission. Syphilis is transmitted from person to person by direct contact with a syphilitic zone known as chancre. Chancre can occur on or around the external genitalia, in the vagina, around the anus, or in the rectum, or in or around the mouth. Transmission of syphilis can occur during vaginal, anal, or oral sex. In addition, pregnant women with syphilis can transmit the infection to their unborn child. Incubation period. The average time between acquisition of syphilis and the start of the first symptom is 21 days, but can range from 10 to 90 days. Stages of syphilis. It includes primary, secondary, latent. It has two types, early and late, and then the late or tertiary syphilis may involve any organ, but mainly are neurosyphilis, cardiovascular syphilis, and benign gumma. Primary syphilis, the chancre. The incubation period is 9 to 90 days, usually averages of 21 days, develops at site of contact or inoculation, classically single, painless, clean base indurated ulcer with firm raised borders. Atypical presentation may occur, mostly anogenital, but may occur at any site, including tongue, pharynx, lips, finger, nipples, etc. Non-tender regional adenopathy, very infectious, may be dark field positive but serologically negative. Untreated heals in several weeks, leaving a faint scar. Secondary syphilis, seen 6 weeks to 6 months after primary chancre, usually diffuse non-pruritic indurated rash, including palms and soles. May also cause fever, malaise, headache, sore throat, myalgia, arthralgia, generalized lymphadenopathy. Hepatitis in 10% of the cases. Renal, an immune complex type of nephropathy with transient nephrotic syndrome. Iritis or an anterior uveitis. In bone, it can cause periostitis. CSF leukocytosis in 10 to 30%, but symptomatic meningitis is seen in less than 1%. Latent syphilis. Positive syphilis serology without clinical signs and without clinical signs of syphilis and has normal CSF. It begins with the end of secondary syphilis and may last for a lifetime. Patient may or may not have a history of primary or secondary syphilis. Disease known to cause occasional false positive. Non-treponemic tests, reactions for syphilis such as SLE and congenital syphilis must be excluded before the diagnosis of latent syphilis can be made. It is divided into early and late syphilis. Latent syphilis. Early. The first year after the resolution of primary or secondary lesions or a reactive serological test for syphilis is an asymptomatic individual who has had a negative serological test within the preceding year. And second is the late, usually not infectious except for the pregnant women who may transmit infection to her fetus. Late syphilis or tertiary syphilis is the destructive stage of syphilis. Lesions develop in skin, bone, and visceral organs. It can be any organ. There are main three types: late benign gummatous, cardiovascular, and neurosyphilis. Can be crippling and life-threatening. Blindness, deafness, deformity, lack of coordination, paralysis, dementia may occur. It is usually very slow progressive, bearing certain neurological syndromes which may develop suddenly due to and arthritis and thrombosis in the CNS, and late syphilis is non-infectious. As you can see, the organism spread to various organs causing lesion or gummas in liver, brain, bone, or heart anywhere. Late benign syphilis, the gumma. The gumma is the most common complication of late syphilis. Gummas may be single or multiple, start as a superficial nodule or as a deeper lesion that breaks down to form punched out ulcers. They are ordinarily indolent, slowly progressive, and indurated granulomata with central healing with an atrophic scar surrounded by hyperpigmented borders. May be destructive but responds rapidly to treatment. Thus, it is relatively benign. As you can see, the different pictures of the gumma on the finger, on forehead, on the foot. So if we summarize the stages of syphilis, it is 3 or 4 stages: primary, secondary, latent, and tertiary. Primary, the hallmark of the primary syphilis is the chancre. In the secondary, there is a rash, and it may involve eyes or liver or everything. And then the next is latent, it's early latent and the late latent, and the last is the tertiary and the gumma, and it can involve any organ. Now comes towards the congenital syphilis. Congenital syphilis is transmitted in utero after the first 16 weeks of pregnancy. Therefore, it is usually not a cause of abortion during the first trimester. The infected child born later in family usually has less severe syphilis. Again, it has been divided according to arbitrarily divided line of 2 years into early and late types. Early congenital syphilis, the features are similar to secondary syphilis. Usually it occurs 2 to 8 weeks after birth, presenting with failure to thrive, mucocutaneous lesions, which are also known as condylometallata, generalized lymphadenopathy, nasal snuffness, and skin rash. Late congenital, the onset usually occurs at or near puberty when no stigmata includes nerve deafness, interstitial keratitis, Hutchins teeth, which is Hutchins triad, then Clutton's joint, osteitis, and chondritis, which includes saddle nose, frontal bossing, and sabritibia, and perforated palate. This, you can see the picture of the baby born with syphilis. The permanent dentation may show characteristic abnormalities known as Hutchinson teeth. The upper central incisors are widely spaced, centrally notched, and tapered in a manner of a screwdriver. The molars may show multiple poorly developed cusps, mulberry molars. Congenital syphilis can cause in the mother miscarriage, stillbirth, prematurity, low birth weight, death shortly after birth. Up to 40% of the babies born to women with untreated syphilis may be stillborn or die from the infection as a newborn. Levels of prevention, as we all know, includes primary, secondary, and tertiary. First of all, in general, the prevention and control strategies for sexually transmitted disease includes the organization of central sexually transmitted disease control. Then there is the primary prevention. Then there must be school health education regarding STDs, and there should be mass media for health promotion and prevention of STDs. Now, particularly coming towards the syphilis, the primary prevention. It targets on individual base, then societal and community, and the policy making and the environment. So it includes these strategic areas: promoting public health policy, promoting a supportive environment, strengthening communication, community action, promoting health personal behavior skills by providing information, education, and counseling, orienting health services toward meeting all the patient needs, specific health education programs regarding safe sex, using condoms, reporting for early treatment, strict compliance. All these factors prevent further transmission of the disease. Specific protection. Syphilis is unique among sexually transmitted disease in that it remains curable with a single dose of penicillin, with no documented risk of resistance. Formulated for this purpose is long-acting benzathine penicillin G, but there is not a vaccine available to prevent syphilis. Secondary prevention includes early diagnosis and prompt treatment. For the diagnosis, the syphilis serological assays includes two types of assays: non-treponemal assays and treponeme-specific assays. First, the non-treponemal assays includes Venereal Disease Research Lab, VDRL, Rapid Plasma Reagent, RPR, Automated Reagent Test, ART. Treponeme-specific assays include fluorescent treponemal antibody absorbed, FTA, ABS, microhemagglutination antibody, treponemal pallidum, MHA, TP, and automated treponemal pallidum enzyme immunoassay. Standard protocol for syphilis screening and diagnosis includes, it starts with a non-treponemal pallidum testing, which is VDRL or RPR. If the test becomes negative, we stop over there. But if the results come positive, then we do treponemal pallidum specific testing, which include TP8, FTA, or ABS. Then again, if the test is negative, then we'll stop. But if the test comes positive, then we assess that patient for the further treatment. So in this, the important is first we go for the non-treponemal testing, and if it comes positive, then we move for the treponemal testing. Treatment of syphilis and the congenital syphilis. Syphilis can affect your brain and other organs, but there's a good news. It's curable with antibiotics. So the primary, secondary, early latent syphilis includes recommended regimes are benzathine penicillin G, 2.4 million units intramuscular. If the person is allergic to penicillin, then doxycycline 100 mg twice daily for 14 days, or ceftriaxone 1 gram intramuscular or IV daily for 8 to 10 days. Limited studies are available according to the trial of the ceftriaxone. And the last is azithromycin 2 gram single oral dose, and it is a preliminary data. Congenital syphilis, proven highly probable disease, aqueous crystalline penicillin G 1,50,000 units per kg per day, administered as 50,000 units per kg dose IV 12 hours during the first 7 days and thereafter 8 hours for 10 days. Or procaine penicillin G 50,000 units per kg dose intramuscular in a single dose for 10 days. Summarizing the whole syphilis, pathogenous treponema pallidum, treatment is available with penicillin. 25% of the people with syphilis die without treatment. As far as the symptoms are concerned, we have stage 1, 2, 3, and every stage has a different presentation, and prevention is for individual, community, and at the government level. Global and national updates. One of the articles regarding the resurgence of syphilis, the CDC issued a new call to action in April 2017 that called for increased surveillance, data collection, and community involvement. This plan came about following a noted increase of cases since 2000. Rate of syphilis have been increasing in men, women, and once again in newborn because of the congenital syphilis. Rate increased by 19% in 2014 and 15, with a similar increase noted in just the first 6 months of 2016. During 2012 and 16, the syphilis rate increased among all race, ethnicity groups. Pregnant women and men who have sex with men have been identified as two of the highest risk population that should be targeted for screening. As you can see the trends, the syphilis case numbers have been increasing in the United States for several years. In 2017, there were more than 27,000 cases reported, an all-time high. Now, stronger action is being undertaken to address this issue. Again, the syphilis cases in US newborns spiked to 20 years high in 2017, according to the report by the Center of Disease Control and Prevention. And you can see by the graph, the newborn syphilis on the rise. The number of babies being born with syphilis have risen 20 years high in the United States. The rise in case of syphilis in newborns known as congenital syphilis might be in part be a result of physicians missing opportunities to screen and treat pregnant women with syphilis. The latest increase in newborn cases mirrors an overall increase in STS cases nationwide, including syphilis in women of reproductive age. Between 2013 and 17, the number of women and girls with early stages of syphilis rose by 148% from 1,500 to 3,722 according to the report. Then again, one of the article by CDC, untreated syphilis in pregnant women, if acquired during the 4 years before delivery, can lead to infection of the fetus in up to 80% of the cases and may result in stillbirth or infant death in up to 40% of the cases. Now the syphilis statistics. As you can see by the graph and the pie chart, the primary and secondary syphilis distribution of cases of sex and sex partners, United States 2018. And by the C, you can see there is a large 48% is a chunk men have sex with the men only. And in the second side, you can see the raising, the graph is on the inclination in African region, Eastern Mediterranean region, European region, regions of America, Southeast Asian region, and Western Pacific region. It's all in all regions, it's increasing. Then one of the article published sexually transmitted infections in Pakistan. It was a cross-sectional study conducted in the patient attending STI clinics from July 2006 to September 2009. In this case, blood and urethral swabs were collected and tested for syphilis, gonococcus, genital herpes, chlamydia, and chancroid. In this study, out of 1,532 patients were consented to participation. Most infections were among aged group 30 to 45 years. Approximately 63.3% of the patients from the rural suburbs, male gender 83.3%, and low socioeconomic status 67% were dominant. Most patients, 89.4% patients were married, and about 79% of patients never attended school. 63.4% patient persons were heterosexual, and 29.9% had both same sex and with opposite partners. And nearly 60% of the patients were aware of modes of transmission of STI and its complication. Genital ulcers were the most common presenting complaint. Painful tender ulcers were recurrent and grouped. Report established baseline local prevalence rate of STI. Syphilis emerged as the most prevalent STI in Faisalabad. Population-based studies are required to study the epidemiology of STIs along with initiation of National Health Education Campaign. National AIDS Control Program, it was established in 1986-87 with a focus on diagnosis of cases that come to hospital but progressively began to shift slowly towards the community focus. In this, the heterogeneity and interlinking of high-risk injecting and sexual behavior combined with low levels of HIV knowledge and prevention and high levels of other sexually transmitted infections. A few of the main objectives of National AIDS Control Program are as under, which has prevention of HIV transmission, safe blood transmission, reduction of sexually transmitted disease transmission, and establishment of the surveillance. There is as far no separate program, national program is going on for any STIs. It's just a part of National AIDS Control Program, which shows a reduction of sexually transmitted disease transmission. So if we see the World Health Ranking of the Pakistan according to latest WHO data published in 2018 syphilis, deaths in Pakistan reached in 8,440 or 0.68% of the total deaths. The age adjusted death rate is 3.04 per 1 lakh of population, ranks Pakistan 26th in the world. Then the recent advances, Global Health Sector Strategy on Sexually Transmitted Infection 2016-21 by WHO towards ending STIs. The present Global Health Sector Strategy on Sexually Transmitted Infection 2016-21 builds in conclusion from the evaluation of the implementation of the global strategy for the prevention and control of sexually transmitted infection from 6 to 15 and set out some VN goals, targets, guiding principles, and priority actions for ending the sexually transmitted infections epidemic as a public health problem. Again, one of the document by the Global Elimination of Congenital Syphilis by WHO. The overarching global goal of the present strategy is the elimination of congenital syphilis as a public health problem. This would be achieved through reduction of prevalence of syphilis in pregnant women and by the prevention of mother-to-child transmission of syphilis. The strategy rests on 4 pillars. Number 1 is to ensure sustained political commitment and advocacy. Second is the increased access and the quality of maternal and newborn health services. Third is screen and treat pregnant women and their partners. And the last is establish surveillance, monitoring, and evaluation systems. Syphilis prevalence trends in adult women in 132 countries. These standardized trend estimates highlight the need of increased investment in national syphilis surveillance and control efforts if the World Health Organization target of a 90% reduction in the incidence of syphilis between 2018 and 30 is to be met. Now it's time for the multiple choice questions. Number 1, non-infectious stage of syphilis reaches in the time period of 6 months, 1 year, 2 years, 3 years, 4 years.
6 months.
No, it's 2 years. Question number 2. Seropositive patients for syphilis can be traced best from hospital records, community survey, antenatal survey, patient referrals, routine medical examination.
C.
No, it's D, patient's referrals. Because of a chain with STIs, they transfer one get to know one patient, it tells about the other patient. So it's the patient referrals. Next question. Diagnosis of syphilis can be confirmed by examination of exudates under microscope, dark field examination, Weismann's test, RPR test, FTA test. No, it's E, FTA test, first and favorable random test. Next, a single painless ulcer to regular margins with no sign of inflammation is a characteristic of
Syphilis.
Next, generalized of flexor of arms, legs, and palms.
Secondary cell.
Easy ones. Next, seropositivity of syphilis 100%. Primary syphilis? Yes, secondary syphilis. Next, latent syphilis can present with no sign and symptoms up to the period of 1 year, 2 years, 5 years, 7 years, 10 years. 5 years. 5 years. One of following is not the characteristic of congenital syphilis. Depressed bridge of nose, frontal nostril, sixth nerve deficit keratitis. No, it's sixth nerve.
B. 6 nerve deafness.
Last is examination is mandated after primary infection. 6 months, 1 year, 1.6 years, or 2.6 years.
2 years.
No, it's A, 6 months. Social hygiene centers are for the treatment of leprosy, diseases of allergy, and drug and substance users.
C. Venereal
It's
disease.
C, venereal disease.
C.
It's the key. These are the references.
Thank you very much.
Thank you so much.
Thank you very much, Dr. Sadi. It is a wonderful presentation as always. The syphilis, very important preventable disease that is cured when it is in the primary and secondary stages. However, whenever it has been progressed to the tertiary stage, it may not be curable. So it is one of the disease where we always raise a slogan that the prevention is better than the cure. Again, you have beautifully described many important aspects of the syphilis, including the pregnancy, primary, secondary, latent, and tertiary syphilis. And the timelines are very important. A person having chancre, they may last for 3 to 6 weeks and will heal without having any important deformity. However, we know that the timelines are very important for from the infection to the first symptom. Usually it is between 10 to 90 days. So the average is about 21 days. We all know that primary syphilis is 100% curable. The secondary syphilis is curable. However, the tertiary syphilis may not be curable. I want to ask more about the ethical considerations of syphilis. If anybody in the class can tell us about the ethical considerations that led to the revelation of the Belmont Report and the later establishment of different boards, if anybody can tell me more about it.
Ma'am, I have no idea about this.
Okay. That very important ethical consideration is about Tuskegee trial. Whenever we talk about the research ethics, we always tell about the case study of Tuskegee. It is one of the research study that has been done on the patients of syphilis. The Tuskegee study of untreated syphilis was in the Afro-American men, and it was unethical natural history of the disease that was followed between 1932 and 1972 by the US Public Health Services and Center of Disease Control and Prevention. What they did at that time, US Public Health Services and CDC, they were looking for the natural history of the disease. They were looking for certain preventions and the treatment that can be offered in syphilis. So they recruited many people in it. The purpose of the study was mainly to observe the natural history of untreated syphilis. The Public Health Services started a study in 1932 in collaboration of Tuskegee University in Alabama. That is why it is called Tuskegee trials. At that time, that university was the institute called Tuskegee Institute. Later, it was named as Tuskegee University. Alabama, why they have selected Alabama? Because the Alabama, there were many black men, that is the Afro-American men of a uh, certain socioeconomical class that were available. So what they did was they never informed the subjects of their diagnosis. As we know that the primary syphilis is curable, secondary syphilis, it is curable. But when it goes to the tertiary syphilis, it is not or it may not be curable. And it can lead to damage, severe damage to the cardiovascular system. It can lead to the damage to the heart, to the brain, to the spinal cord. It can causing severe pain in those people who are having tertiary syphilis. Even they can be paralyzed and their life can be miserable, but they were never informed about their diagnosis. Second, the placebo group that was disguised. Third is the participants were told that the study would end in 6 months, but actually that study remained for 40 years. So whenever we talked about deception in research, we always refer to the case study of Tuskegee trials, where the participants were told that the study would end in 6 months, but actually they keep on researching for 40 years. When the funding was lost, the men were not treated despite the fact that penicillin was widely available and it was known that the penicillin can treat them. Similarly, these all these things that were noted by the committees, that lead to the revelation of Belmont Report. In 1979, we have the Belmont Report, that is a document for research ethics. Again, we have now institutional review board that is for the protection of humans, and even in US there is a office for human research protection. So all these important landmarks that have been achieved in research, it is after this unfortunate event of having Tuskegee study that was done on syphilis, and it led to the different phases of this syphilis without given treatment. Now, at this point in time, when we are doing different researches, we are all bound to have our IRB approvals. And without institutional review board, no one can do any research.
Yes, ma'am.
I think, yeah,
It's
this
quite
is one of a very
much,
important thing
very valuable information being
that
shared.
is Dr. Sadia, would you please tell me more about how the vertical transmission from the mother to the child can be prevented in syphilis?
Okay, ma'am. Ma'am, it's being said that the mother, the lady is being infected with the syphilis even before the pregnancy, 4 years before the pregnancy. And then, even then, the baby would have the 80% chances of have syphilis, congenital syphilis. So it's basically in the second trimester. If she gets syphilis, it would be in the second trimester, and we have the options to treat her with the penicillin. And now the things have been changed. We have at the 20 weeks, we have the scan for and congenital anomaly scan. And nowadays, if the patient has a history or something like that, TOSH infections are usually done to rule out any STIs. But if it is that the 20-week scan is good enough for the congenital anomalies, and after that, if the person radiologist picks any abnormality, then we could decide even at the early term because about the termination of the pregnancy. Because to treat or a cure of a baby, the mortality rate is very high. 40% of the cases, babies will die, infants will die after delivery. And if they will survive, then they would have early and late complications. Nowadays, it could be an approach about the termination of the pregnancy early, or about knowing the mother is having this sort of a pregnancy. And this is treatable during pregnancy, and for the child as well, he or she has to bear the congenital anomalies. Yes, ma'am.
Thank you very much. This is very nicely explained. And I think if you have any question, please do ask us. Okay, Allah bless you all. Allah Hafiz. See
Allah.
you tomorrow, inshallah.
Thank you so much, ma'am. Assalamu alaikum. Allah Hafiz.